Good morning, everyone. I'll be talking about, my name is Dr. Melanie Gomes, Senior Resident with the Department of Orthopedics, Sri Lakshmi Narayan Institute of Medical Sciences, Puducherry. I'll be talking about Perthes disease today. By definition, is a condition in which the blood supply of the capital femoral epiphysis is disrupted, resulting in epiphyseal osteonecrosis and chondronecrosis with cessation of growth of the ossification nucleus. The necrotic bone is eventually resorbed and replaced by new bone. During the resorptive phase, the mechanical properties are weakened such that the femoral heads develop a flattened deformity called coxa plana. Reossification, and during the reossification phase, the femoral head resumes growth with some overgrowing coxa magna and remodels to variable degrees of roundness. It's most prevalently seen in children in the age group of 4 to 8 years with a male to female ratio of 4:1 or 5:1. Bilateral involvement of hips occur in 10 to 13% of the patients. It was first described by 4 individuals: Arthur Legg from the US, Jacques Carve from France, George Perthes from Germany, and Henning Waldenstrom from Sweden. Legg described the prominent characteristics of the disorder, that is the age of onset, history of trauma, painless limb, minimal or no spasm, shortening of the affected limb. And Carve noted that affected individuals have minimal atrophy of the leg and no palpable leg swelling. Perthes observed that the disorder was a self-limiting, non-inflammatory condition affecting the capital femoral epiphysis with stages of degeneration and regeneration, leading to restoration of the bone nucleus. Waldenstrom reported radiographic changes associated with the disorder. Coming to the arterial status of the femoral head, the primary blood supply to the capital epiphysis comes from 2 anastomotic arterial rings located around the neck of the femur. The medial and lateral circumflex arteries from the extracapsular ring, and most of the blood is supplied by the medial circumflex artery. The major arterial supply to the femoral head is from the lateral segment of the arterial ring, which is the terminal branch of the medial circumflex artery. After penetrating the lateral capsule in the posterior trochanteric fossa, this blood vessel becomes the lateral ascending cervical artery. As the blood vessel advances between the trochanter and capsule, it courses through a narrow passage, an area particularly constricted in children younger than 8 years of age. A subsynovial intracapsular ring joins 4 ascending cervical arterial groups. The intracapsular ring has been found to be incomplete more often in boys than girls. No blood vessels cross the epiphyseal plate, and minimal blood is supplied through the ligamentum teres. The venous drainage of the femoral head and neck. Abnormal venous drainage of the head and neck has been noticed in patients with LCPD. Increased venous pressure in the affected femoral neck and associated venous congestion in the metaphysis results in ischemic necrosis. Venous outflow has been found to exit more distally through the diaphyseal veins. It is unknown whether the venous obstruction is cause for the disorder, a secondary effect of some other pathological process. Coming to the etiology. Factors that may be etiologic are like trauma, susceptibility in a child, hereditary factors, coagulopathy, type 2 collagenopathy, hyperactivity, passive smoking. Factors that are unlikely to be etiologic are endocrinopathy, urban environment, and cosynovitis. Especially coming to trauma in the predisposed child precipitates AVN of the femoral head and the development of LCPD. Lateral epiphyseal artery courses through a narrow passage, making it susceptible to disruption after trauma. And there's increased risk of vascular interruption due to trauma as the vessel has to pass through the thick cartilage of the femoral head. Hereditary influence. Authors have suggested genetic factor as a possible cause of LCPD, as they have noted the disorder in 44% of 4 generations of one family. Polygenic inheritance has been suggested. X-linked recessive factor and an autosomal homozygous allele were present in each genotype. G455 or polymorphism of beta fibrinogen has been associated with LCPD. Hyperactivity Hyperactivity or tension deficit disorder. The precise role in the disease is unclear. High prevalence of Perthes disease is seen in patients with attention deficit disorder. As they grow older, they were in a perpetual state of motion and were prone to climbing and falling. ADD is associated with greater mechanical loading of the hip joint and increased subclinical trauma that could influence pathogenesis of femoral head deformity and outcome. Type 2 collagenopathy. Improvements in socioeconomic and nutritional status has been proposed as factors associated with decline in the incidence of LCPD. Low levels of blood manganese have been found in affected children. Passive smoking is known to lower stimulated tissue plasminogen activator activity, leading to hyperfibrinolysis and possibly venous occlusion of femoral head vessels. Coming to the pathological findings. In the early stage, this is called the stage of increased density. You'll have areas of necrotic bone with absent or pycnotic nuclei of osteocytes, dead trabecular bone and marrow necrosis called tumora, collapsed trabeculae, physeal disruption, subchondral fracture, separation of cartilage bone junction, necrosis of deep layer of epiphyseal cartilage, thickened articular cartilage, cartilage extending from physis into metaphysis. Fragmentation stage. Invasion of vascular granulation tissue in the marrow space, increased vessels in the cartilage, increased osteoclast, bone resorption in the bony epiphysis, restoration of enchondral ossification in the periphery of epiphysis. During the reossification stage, there's new bone forming on old trabeculae, woven new bone formation. During the healing stage, the new bone, woven and lamellar, and return to normal architecture. Coming to the natural history. Treatment programs were started as soon as LCPD were identified, hence there's no definitive natural history. Most children experience moderate symptoms and endure 12 to 18 months of difficulty, followed by gradual resolution. Age of patient at onset of disease is the most important factor affecting the course. Younger the child, better the outcome. Less than 4 years, asymptomatic, no deformity, Meyer's dysplasia. 4 to 6 years early onset, mild disease. 6 to 9 years, moderate symptoms. 9 years and older is usually a severe course with a poor outcome. Coming to the symptoms. Limp, exacerbated by strenuous activity and alleviated with rest. Usually first noticed by a parent. Pain, which may be located in the groin, anterior hip, or laterally around the greater trochanter, worse late in the day. Referred pain to the knee or anterior thigh. Parents may recollect an isolated incident of trauma several months earlier. After a few days of onset, the initial symptoms may resolve completely. The patient often has waxing and waning of symptoms. Some patients may exhibit ADD. Child may be smaller in stature than peers. Sometimes the relative of the family may have the disorder, though family history is rare. Coming to the signs. Limp, usually antalgic with the Trendelenburg gait. Trendelenburg test is usually positive. Muscle atrophy. Early disease, slight loss of abduction and internal rotation. Log roll test would be positive. During the late stages, greater loss of abduction and internal rotation, hip flexed with obligatory external rotation, and adduction contractures. Coming to the clinical findings and radiologic stages. In stage 1, which is called the increased density stage. Usually there'll be limp with variable pain and often mild and intermittent. Radiographic changes, increased density of the femoral head with or without subchondral fracture. During the fragmentation stage, pain and limp may worsen, may lose range of movement. Head radiographic changes, head shows fragmentation, may lateralize and flatten. Reossification stage. Limp and pain gradually resolves, the ROM improves. Femoral head gradually reossifies, flattening may improve. Heel stage, there's occasional limp, occasional locking or popping, and on X-ray we see they may develop osteochondritic lesions. Waldenstrom classification based on radiographic changes in the femoral head. This again is classified as stage 1, 2, 3, and 4. Stage 1 is the stage of increased density, which usually lasts around 6 to 14 months. On X-ray, we'll see an ossific nucleus, which is smaller. Femoral head is uniformly dense. Subchondral fracture, which is the Waldenstrom sign, and radiolucencies appear in the metaphysis, the sagging rope sign. Next is the fragmentation stage, which is appears at around 8 months and lasts for around 2 to 35 months. Varying patterns of lucency in the epiphysis, segments of the femoral head are demarcated. Femoral head may flatten and widen. Metaphyseal changes resolve in this stage, and the change in the acetabular contour. Stage 3, which is the healing or the reossification stage, this usually appears at 51 months and continues for 2 to 112 months. Here, new bone appears in the femoral head, which reossifies. Epiphysis becomes homogeneous. Stage 4 is the healed or the remodeling stage. The femoral head fully reossifies and remodels to maturity, and the acetabulum also remodels. Joseph and cohort also have a modified classification, which is stage 1A, B. This is the increased density stage, where A, there's no loss of residual height, B, there's some loss of height, and this is usually between 3 to 4 months. Stage 2A is earliest fragmentation around for 4 months. 2B, more advanced fragmentation, 4 months. 3A is first appearance of newborn formation, which is 7 months. 3B, newborn formation, normal texture over 1/3 or more epiphysis, 11 months. And stage 4 is fully healed hips. Catch-all classification of 1971, again, 4 groups. The first one is anterior portion of epiphysis affected. Stage 2, more of anterior segment is involved. Central sequestrum present. Affected segment collapse. Epiphyseal height preserved. Here, a benign prognosis, no intervention is required. In group 3, most of the epiphysis is sequestrated. Unaffected portions, medial and lateral to central segment. And stage 4 is complete sequestration of epiphysis. Here, treatment is required. Now, head at risk signs have been described by Catterall. These include lateral subluxation of the femoral head, radiolucent V in the lateral aspect of the epiphysis called gauge sign, calcification lateral to epiphysis, and horizontal physeal line. The head at risk factors indicate an increased chance of poor outcome. SALTER-THOMPSON classification. Based on the extent of the subchondral fracture in the AP and lateral views, we classified as group A and group B. Group A is involvement of less than half the femoral head. Group B is involvement of more than half of the femoral head. Application of classification restricted only 30% is restricted as only 30% patients have fracture at the time of presentation or follow-up. Lateral pillar classification of 1992. Here, the radiographic change in the lateral portion of the femoral head. It's based on the radiographic change in the lateral portion of the femoral head. That is the fragmentation stage. We have 4 groups. Group A, where there's no density change, no loss of height. Group B, where there's some density change, height of more than or equal to 50%, central pillar collapse. BC with thin lateral pillar, borderline height, and C where the height is less than 50%. Coming to the investigations. MRI is the most accurate modality for early diagnosis. Visualization of configuration of femoral head and acetabulum. Dynamic gadolinium enhanced subtraction MRI delineates epiphyseal necrosis early. Recognition of early reperfusion patterns. The next investigation that can be done is scintigraphy. A technetium scanning, it's a sensitive means for early diagnosis. It gives accurate information about the extent of necrosis. It detects revascularization and stage of the disease. A track or pathway, recanalization of existing vessels, take a few days. B track or pathway, neovascularization can take months to years. Disadvantages of scintigraphic classification. Routine static scintigraphy or SPECT is not adequate. It requires 2 serial scintograms, lacks tissue confirmation of recanalization and neovascularization pathways, and intra-observer and inter-observer reliability is moderate. Arthrography. This shows the configuration of femoral head and its relation to the acetabulum. Provides information about the containment of femoral head within the acetabulum. The advantage of this is the examiner can assess congruity of the hip in many different positions. Currently, assessment of loss of hip containment and hinge abduction of the hip. Ultrasonography. In early stages, we only see joint diffusion, and in later stages can help to assess the shape of the femoral head. Evaluation of blood flow in the head can be done with ultrasound, with microbubble contrast enhancement and Doppler ultrasound. Computer tomography. It gives an accurate 3D image of femoral head and acetabulum, which is not used routinely. Benefits in the later stages: evaluate pain, locking of the joint, mechanical symptoms. Classification of the end results of Perthes. One is most classification. Classified using the AP and frog lateral views, based on the fitting contour of the healed femoral head to a template of the concentric circles. A good outcome will be seen if the shape of the femoral head deviates less than 1 mm from the given circle. A fair outcome is seen if the shape falls within 2 mm, and a poor outcome if the deviation is more than 2 mm. Easily reproducible, but limited. Stulberg's classification. Radiographs of the hips at skeletal maturity, AP and frog lateral views. This is again classified 4 groups. Group 1, the femoral head is normal. Group 2, the femoral head is round within 2 mm of the circle, same circle both views. Group 3, the femoral head is ovoid, acetabulum matches the head. Group 4, the femoral head is flattened more than 1 centimeter on weight-bearing scales, acetabulum is flattened. And in Group 5, the femoral head is collapsed, acetabulum is not flattened. What are the problems of management? One is the deformation of the femoral head, enlargement of the femoral head, capital physeal growth impairment, secondary degenerative arthritis of the hip. Aims of treatment. One is prevent deformation of the femoral head, minimize the enlargement of the femoral head, prevent or correct greatotrochanteric overgrowth, prevent secondary degenerative arthritis of the hip. Coming to treatment options. One is weight relief. In the past, the mainstay was avoid weight bearing for a prolonged period. This prevents deformation of the femoral head, little evidence of being effective when used in isolation. Then containment by bracing or casting. Repositioning of the extruded anterolateral part of the femoral epiphysis into the acetabulum, abduction and flexion or abduction and internal rotation of the hip. Various braces, A-frame, sole rails, worn up to 2 years. Containments need to be ensured until later part of stage of regeneration, or the broomstick cast, which is also called the Pucci cast. Surgical containment, these are the following options: femoral osteotomy, pelvic bone surgery, femoral osteotomies, proximal fragment, either abducted internally rotated, which is the femoral VDO, or abducted and flexed, which is VEO. Pelvic bone surgeries are usually augmentation or reorientation of the acetabulum. Varus derotation osteotomy, which was first introduced in the 1960s. It is an intertrochanteric or subtrochanteric osteotomy, where the distal fragment is adducted and externally rotated to the same degree of abduction and internal rotation of the hip required. 20-degree varus angulation and 20 to 30-degree derotation. Osteotomy is held with a plate and screw. In less than 12 years of age, open wedge osteotomy, no risk of delayed union. All hip movements are restored to normal before surgery. Performed within 8 months of onset of symptoms. Trochanteric epiphysiodesis when trochanteric overgrowth is likely. Varus extension osteotomy. If passive internal rotation remains restricted following traction or casting, and a rotational osteotomy is done to reposition the posterior portion of the femoral head in the acetabulum. Come to the complications of femoral osteotomy. Excessive postoperative varus, failure of varus to remodel, persistent external rotation of the limb after rotational osteotomy, shortening of extremity, increased abductor lurch, resulting in abductor limb, trochanteric overgrowth, need to remove the fixation device, fracture after removal of plate. Pelvic surgeries. The following are some options of pelvic surgeries. One is the shelf operation, which was first introduced in 1940. Here, this is creating a bonus
Salvage
shelf to cover
surgery
the excluded parts of the
sequelae for those who
epiphys.
present too
It is
late in the course
performed
of
in
the
other
disease.
non-operative
Aims of the treatment are to relieve pain,
It
correct
stimulates
the trendulum bug
acetabular
gait,
depth
minimize
growth.
risk of development of degenerative arthritis.
Gill said the
Salvage
deep
options
notch
are valgus osteotomy of the proximal
deep
femur,
notch
joint
made above the
distraction,
acetabulum,
arthrodesis, scalectomy, greater
acetabulary
trochanteric advancement,
right down.
flattening of the femoral head, improving
Complications of this are
acetabular
loss of
muscle
inflection and inadequate hip coverage.
Indications: incomplete
Next
healing
option
or
is the
heel, abduction,
redirectional
painful, spherical head, hip
also
congruent
called
abduction,
SALTER-THOMPSON.
demonstrated hinge abduction, valgus intertrochanteric.
Here, the acetabulum is
Heel disease, no
reoriented,
pain, large
which
spherical
increases the
femoral
coverage
head
of the
with uncovered
anterolateral aspect of femoral
inordinate
epiphysis.
osteotomy or
There's
self-operational
minimum
acetabular
deformity,
augmentation.
non-irritable hip,
Heel
no
disease,
restriction
no
of
pain, large
power.
flattened head with
Hip
uncovered
abduction of 45
self-operational
degrees,
CHIARI osteotomy.
containment
Heel
in that
disease, no pain,
position.
spherical head,
Capsule is not open, and the iliopsoas and adductor muscles are lengthened.
trochanteric advancement can be done. Heel disease pain, irregular femoral head, hip not congruent.
Calonchi version, with the distal pelvic fragment repositioned into a notch posteriorly in proximal side of resected ilium. CHIARI osteotomy, reserved for healing femoral head that remains lateralized. Older children, painful hip, significant femoral deformity, incongruity between head and acetabulum. Greater trochanteric arrest. Epiphysiodesis slows down the growth of greater trochanter. Older children with VDO, drilling growth plate of greater trochanter and transfixing the greater trochanteric growth plate with a screw. Treatment for under 12 years of age. If the age of onset is less than 5 years, any degree of epiphyseal involvement, no extrusion in stage 1, 2, or 3 of the disease, no active intervention, periodic review until healing. If the age of onset is less than 5 years, half or more of epiphysis involved, extrusion present in stage 1 or 2 of the disease, contained with a base in abduction and flexion of the abduction and flexion or abduction and internal rotation. If the age of onset is less than 12 years, less than half of the epiphysis involved, no extrusion in stage 1 or 2 of the disease, no active intervention, periodic review until healing. If the age of onset is between 5 to 7 years, half or more of epiphysis involved, extrusion present in stage 1 or 2 of the disease, a VDO if all hip movements are restored, or VEO if internal rotational load is limited. If the age of onset is between 7 to 12 years, half or more of epiphysis involved, extrusion present or absent in stage 1 or 2 of the disease, a VDO or a VEO plus trochanteric arrest. If the age of onset is less than 12 years with half or more of epiphysis involved, extrusion present in stage 3 of the disease and hip pain, treat the pain with rest and traction until relieved, and residual problems, salvage procedure is done. Salvage surgery for sequelae. For those who present too late in the course of the disease, aims of the treatment are to for salvage surgery for sequelae, for those who present too late in the course of the disease, aims of the treatment are to relieve pain, correct the trendulum bug gait, minimize risk of development of degenerative arthritis. Salvage options are valgus osteotomy of the proximal femur, joint distraction, arthrodesis, scalectomy, greater trochanteric advancement, lengthening of the femoral head, improving acetabular coverage of the femoral head. Indications: incomplete healing or healed, abduction painful, spherical head, hip congruent in adduction, demonstrated hinge abduction, valgus intertrochanteric osteotomy. Heel disease, no pain, large spherical femoral head with uncovering hip congruent, inordinate osteotomy or self-operational acetabular augmentation can be done. Heel disease, no pain, large flattened head with uncovering hip congruent, self-operational CHIARI osteotomy can be done. Heel disease, no pain, spherical head, hip congruent, coxa brava, or trochanteric overgrowth with tendon working, the trochanteric advancement can be done. Heel disease pain, irregular femoral head, hip not congruent, arthritic changes, arthrodesis needs to be done. Thank you.